Welcome to the narrated presentation titled Discussing Infectious Concerns About Residents with Family Members and Caregivers. In this presentation, we are going to discuss some scenarios that may occur when talking about infectious concerns with residents and their family members. Antibiotics have traditionally been seen as harmless, though as we've discussed throughout the resources of this program, antibiotics do have harms as well as benefits. We will review strategies to discuss the potential harms of antibiotic use with family members. We will also address end-of-life care as it relates to antibiotic use. Finally, we will discuss approaches to providing supportive and comfort care measures for residents who are uncomfortable, which may not involve antibiotics. We hope to give you some options for a practical dialogue you can use when family members request antibiotics that may not be indicated. Let's recall a few important concepts from our previous module regarding effective communication. These concepts can be applied to communication with other medical providers and when discussing infection concerns with family members. Effective communication should be complete. Try to communicate all relevant information while avoiding unnecessary details. Clear. Use lay terminology and make sure the resident or family member understands. Brief. Being concise is key, especially with heavy workloads and time distractions. Finally, it should be timely. Communication should be provided in regular updates to family members and providers regarding status changes of the resident. Social pressure can drive antibiotic prescribing. Research shows that family pressure to prescribe antibiotics is common in long-term care, and this often drives unnecessary prescriptions. Family members are concerned about their loved ones. They have likely been told at some point that an infection, most often a urinary tract infection or UTI, is a common cause of mental status changes. In fact, a variety of other factors are more common causes to a change in mental status, including pain, constipation, and even a poor night's sleep. Education and involvement of family members in the care plan can reduce social pressure to prescribe antibiotics. Consider the following quotes. These are excerpts from a 2014 study that conducted interviews with physicians working in long-term care facilities regarding their decisions to prescribe antibiotics. A junior female doctor who is 30 years old stated, "If they, the family, insist, then we should do it, prescribe antibiotics, because I don't know the man, so it's difficult to predict. I think it won't make much of a difference, but still if the family really insists, then I am quite willing to prescribe antibiotics." A 48-year-old male elder care physician proclaimed, "I just happened to have had some patients recently of whom I thought in retrospect I just shouldn't have done it, prescribed antibiotics. But sometimes you do it for the family. In the past, I used to be more principled about this. I would say, look, you shouldn't do this. And now I think, well, it's a process for them too. So if they can't go along with that yet, then I don't push harder." Do these seem relevant to practices that occur in your facility? Can you understand the pressure or underlying reasons for prescribing? Consider how this may change if a small amount of time is dedicated to having an open discussion with family members about these issues. Let's jump right into a case. You are approached by the daughter of Maria Alvarez, a long-term resident with a history of Parkinson's disease and dementia. Maria refused breakfast and seems less vibrant than she usually is. She also keeps talking about her husband, who died several years ago. Maria's daughter says that the last time this happened, her mother was diagnosed with a UTI, and she requests a urine culture. How do you respond? Consider the following options. 1. That is strange. Let me come in and take a look at her. This is a good option. You should always evaluate a resident that a family member expresses concern about. This makes the family feel that you are adequately addressing their concerns. 2. I think she's fine. Older people often refuse breakfast, but we'll keep an eye on her. This is not a great answer. The daughter will probably feel that her concerns are not being adequately addressed, and she may feel dismissed. 3. Sure, let's check her urine, and I'll call the doctor about starting some antibiotics. This may be an easy answer, but is probably not the best answer in this case. You have not yet evaluated the resident, and without urinary symptoms or other evidence of infection, a urine culture is not indicated. 4. She looked fine last night. She is always a little confused because she has dementia. Again, this may be an easy answer, but this can make the family feel dismissed, and it does not address the daughter's concerns about her mother. You make the right decision and decide to go evaluate Ms. Alvarez. She is sitting in a chair looking out the window. Her vitals are all within normal ranges. She has no catheter, no wounds, and no pain on exam. She cannot verbalize any symptoms, and she tells you she did not eat breakfast because she is waiting for her husband to join her. Your assessment is that Ms. Alvarez is clinically stable and is a bit more confused than baseline. While she does have baseline dementia, she doesn't usually talk about her husband, so this is a new clinical change for her. Let's circle back and communicate with the daughter. First, in addition to your assessment, communicate to the daughter that you have listened to her concerns. I agree that she seems a bit more confused. Now let's address those concerns. Start with empathy and understanding, then explain your plan and reasons for that plan. Finally, offer solutions and reassurance. The daughter's main concern is that her mother is more confused this morning. Try to empathize and understand that concern. You might say, "It must be hard to see your mom like this. She must be very different from the person you knew even just a few years ago." Remember that while family members may have a lot of requests and can sometimes seem difficult, it is usually because they are worried or concerned about someone they love very much. They may be grieving the loss of the mother or significant other they've known, who is now harder to recognize with dementia. There are likely other strong emotions at play, like fear, anger, and guilt. Sometimes family members just want something to be done in hopes of making their loved one better, which may not be realistic. Some may ask for specifics that may not be appropriate, such as urine cultures or chest films or antibiotics. You can offer them other options such as hydration, nutrition, and/or reorientation. These are also tasks that family members can participate in, which may help them regain a sense of control. Next, explain your plan and the clinical reasoning behind a decision to consider antibiotics only when they are necessary. There are several options to try. Let's go through all of them because we expect you'll have many chances to use these in real life. Physically, your mom looks okay. She does not have a fever and her assessment is normal. I understand you are concerned, but she does not have signs or symptoms of infection right now. There are lots of reasons why she might be more confused today. Research from the last few years tells us that UTIs are not really a common reason for confusion. Sometimes a bad night's sleep or a change in medication can make someone confused. Sometimes even just a little dehydration can affect an older adult. You might also explain the difficulties with collecting a good urine sample. You know, it's really hard to get a clean urine sample. Often when the culture comes back looking positive, it's because of contamination. To get a really good sample, we may have to do an in and out catheterization, which is pretty uncomfortable. Or you can address the downsides of getting a urine culture. Getting a urine culture could lead to treating her for an infection she does not have. She might be better tomorrow, but when the urine culture comes back, if it has bacteria in it, sometimes prescribers feel obligated to treat for infection, even though she's not sick. So this could lead to her getting a medicine she does not need, which poses its own risks. Or you can talk about the risks of antibiotics in general. Antibiotics are pretty strong medications, and we want to use them only when we know they are necessary. They can have significant side effects, including allergic reactions, diarrhea, or other GI upset. Sometimes they cause people to get an infectious diarrhea called C. diff that makes them need more antibiotics. Exposure to antibiotics also puts her at risk for developing infection with resistant bacteria, which may make future antibiotics less effective. If family members recognize that you also want to protect their loved one, they may be less likely to pressure you about antibiotics because they are reassured that you are on their side and also concerned. Finally, let's offer some things to try to solve the problem. This includes a plan of care from the healthcare team. We've talked about careful observation or active monitoring before. Just as a quick reminder, active monitoring is often a great way to avoid unnecessary antibiotic starts in residents with no clear evidence of infection. It is often hard to tell if someone had a rough night, is dehydrated, is in pain, is reacting to a medication change, or has early signs of an infection. Most residents will improve with supportive care alone. A plan for active monitoring should address the family's concerns, and it ensures that you do not miss a potential clinical decline. Let's tell the family about our plan for active monitoring. We will watch her closely over the next 24 hours and get vitals on a regular basis. It is possible that she is dehydrated or did not get enough sleep last night. I think we should try and make sure she drinks enough fluid and continue to reorient her. You also engage the family members. If you're going to be here for a while, maybe you can encourage her to drink some water or juice. And end with reassurance that you'll be more responsive if there are changes that suggest a more serious clinical concern. Tell the family, if she does not get better in the next day or two, we'll talk again and see what else we can try. We have also provided some delirium cards under Tools on the AHRQ Safety Program website, which may help start the discussion with family about other causes of mental status changes. These cards offer some tasks that family members can do to help reorient someone with delirium. These cards help the family and nursing staff identify delirium and understand some of the common causes that may lead to delirium symptoms. Notice that there are a variety of causes not related to infection. They also provide some supportive interventions that allow nursing and family members to proactively prevent and treat delirium. These should be attempted before starting antibiotics if there is no evidence of infection. Thanks to your excellent communication skills, Ms. Alvarez's daughter agrees to the plan for active monitoring and helps encourage her to drink some juice and then eat lunch. By next morning, Ms. Alvarez seems back to her baseline and her daughter is relieved. Better yet, she understands why you made the decision you did and that she should not jump to asking for antibiotics every time her mom has a change in mental status in the future. She says she likes the idea of avoiding even more medications for her mother. Let's shift gears now and discuss end-of-life care, which can be a significant driving factor for unnecessary antibiotic prescriptions in the long-term care setting. Antibiotics are often prescribed to people who are dying, even when they don't have symptoms of a bacterial infection. Studies have shown that 42% of nursing home residents with advanced dementia are prescribed antibiotics during their last 2 weeks of life. 25% of hospice patients receive antibiotics during their final weeks of life. Remember that antibiotic therapy carries risks, particularly for frail, elderly patients. The decision to start antibiotics in someone who is approaching the end of life poses risks. These include the potential for rehospitalization and invasive diagnostic testing or procedures such as blood draws, catheter insertion, or the need for intravenous access. Also, like all medications, antibiotics have potential side effects such as rash, gastrointestinal symptoms, or even Clostridioides difficile or C. diff infection, all of which can lead to increased discomfort. The risks of antibiotic use may not align with people who have expressed their wishes for comfort as the main goal of their end-of-life care. Also, as we've discussed before, inappropriate or unnecessary antibiotic use has the potential to negatively impact broader public health outcomes by contributing to the selection of resistant organisms that can be transmitted to other residents at the facility and through those individuals to other healthcare settings. Let's walk through one more case. Hannah Jones is a 72-year-old woman who was recently transferred to your facility for hospice care for a stage 4 metastatic lung cancer. She has brain metastases and has a limited capacity to make medical decisions. Over the last several months of her illness, she made it clear to her family and healthcare team that her goal was to die comfortably, and her family was in agreement with these wishes. A few days after she is transferred, she develops a productive cough. You are approached by her husband. He says, "I think she has pneumonia. She's been coughing like crazy. We better start her on antibiotics." You go in to evaluate Ms. Jones. She has a productive cough and crackles at the base of her left lung. She has no fever and no increase in oxygen requirements. She is lying in bed, breathing comfortably on her baseline oxygen level, 2 liters per minute by nasal cannula. What is your next step in management? Call the physician and suggest a need to start antibiotics. Get a chest x-ray and sputum culture. Review her advance directive. Offer supportive care and comfort measures. The correct answer is to offer supportive care and comfort measures. At this time, she has no fever and no worsening oxygen requirements. Other than the cough, she is at her clinical baseline. Before leaving the room, you offer comfort and support and some other supportive measures, including humidified oxygen, giving her the option of getting oxygen through a mask because it's hard to inhale through her nose when coughing, tissues in a cup at her bedside to spit into, additional pillows, including one to hug while she's coughing because she complained of being sore from coughing so much, refilling her water pitcher, lozenges, cough suppressants. You also review her advance directive. She is DNR/DNI and has requested no life-prolonging interventions. Her goal is comfort care. You return to discuss with her husband. Of course you are concerned about your wife. I think we should set up a time to review her advance directive and your goals for her care. Defining care goals early on in the process, before emergent situations come up, is always better. In this situation, it is appropriate to sit down and have a family meeting. While she does not clinically appear to have pneumonia at this time, Ms. Jones may suffer multiple bouts of pneumonia given her underlying disease, and the progression of her disease may also look like pneumonia, making it hard to tell the difference. Understanding her wishes prior to exposing her to potential discomfort is important. Let's go over our elements for effective communication. First, communicate to the husband that you have listened to the husband's concerns. I understand why you are concerned about this cough. I hear it and it sounds pretty rough. Now let's address those concerns. You've already done a lot by providing comfort measures. Let's continue with some empathy and understanding. Then explain your plan and reasons for that plan. Finally, offer solutions and reassurance, which may have to include revisiting the goals of care with the husband and other family members. We'll start with some empathy and understanding. Here are some types of statements to try. This must be so hard for you to see her suffer with such a wretched disease. We expect her to have a cough as the lung cancer progresses. It is possible that your wife has pneumonia. This is a common infection at the end of life. Next, let's talk about reasons why antibiotics might not be started in a terminally ill woman. Inform the family that infections are expected at the end of life and can often be the terminal event. You might say, people in hospice care often die from infections. What we understand is that attempting to treat infections doesn't change the overall situation and sometimes decreases comfort. Even if an infection is treated, the terminal illness will remain. Try using words to the effect of, even if we treat her for pneumonia, it won't make her any better than how she was a day or two ago. Explain what evaluation and treatment of infection may entail. You might mention that aggressively treating potential infections at the end of life may require rehospitalization and could result in distress and discomfort for their loved one. Even if oral antibiotics can be given in the facility, they can result in significant side effects, such as rash, kidney injury, or diarrhea, and these side effects should be considered if comfort is the main priority. It is helpful to provide alternative palliative or comfort measures to help to provide symptomatic relief and keep the resident's comfort at the end of life at the forefront of treatment goals. In this case, you can help make her coughing more effective by providing good pulmonary toilet. We can try to make her more comfortable by making it easier to cough phlegm out of her lungs. We can give her humidified oxygen and nebulizer treatments. Over-the-counter medications can help. Guaifenesin helps to break up thick mucus and is in most cough medicines. You can also work with the healthcare team to offer cough-suppressing medications. You might tell them some medications like codeine or morphine will help suppress the cough reflex, which means she can get some rest. They also cause sedation and will make it easier for her to be comfortable. Finally, have a family meeting to discuss goals of care. It's important to establish resident and family goals of care. Depending on the situation, this may need to happen more than once. If the resident's main goal is life prolongation rather than comfort, then antibiotics could be indicated if there is evidence of infection. If the resident's main goal is comfort, consider not starting antibiotics as they may prolong suffering or lead to additional adverse events. While symptoms from pneumonia can be treated to sometimes improve comfort, the addition of an itchy, painful rash or cramping and frequent diarrhea from C. difficile would be very uncomfortable at the end of life. Reassure the resident and family that you will continue to provide symptomatic relief and keep the resident's comfort at the end of life at the forefront of treatment goals. These are emotionally difficult conversations to have. While you may have experience with caring for someone at the end of life, this is a new and frightening experience for most residents and family members. Sometimes they want some measure of control over tragic life events. Acknowledging these struggles may help some residents and families find some measure of peace. Keep in mind the risk and benefit balance at the end of life of all medical decisions, including antibiotics, differs for each patient. This balance and the decisions around it may need to be revisited over time as a patient needs and wishes change. We have now completed the Communicating Infectious Concerns with Family narrated presentation. Some key points included: effective communication is a key component to ensure resident safety and family satisfaction with care. Educating residents and family members about the risks of antibiotic treatment is imperative prior to treatment. End-of-life care goals should be established early on in the treatment plan. Thank you for your attention. Feel free to review the entire presentation as many times as needed. The findings and recommendations in this narrated presentation are those of the authors, who are responsible for its content, and do not necessarily represent the views of AHRQ. No statement in this narrated presentation should be construed as an official position of AHRQ or of the U.S. Department of Health and Human Services. Any practice described in this narrated presentation must be applied by healthcare practitioners in accordance with professional judgment and standards of care in regard to the unique circumstances that may apply in each situation they encounter. These practices are offered as helpful options for consideration by healthcare practitioners, not as guidelines.